Tammy, and then Matt. I mean, when I look at ASCO, when I look at ASH, I was just looking at EHA abstracts. I mean, it's like session after session of safety of CAR T cells, and my eyes glaze over as a non-transplanter, I have to say. What's your take on? I mean, we know there's cytokine release. We know there are neurologic toxicities. We know that steroids can potentially help, might affect efficacy. Also, kind of how do you package all this together in a way that I think tells us what to do going forward? First, Cami, your thoughts, and then Matt after that.
Yeah, so as you mentioned, the steroid, or as you mentioned, the neurotoxicity and the cytokine release are the two biggest concerns with these therapies. And I would say there's a little bit of difference in the products, but the two approved products, one has a little bit higher rate of higher grade neurotoxicity, one has a little bit higher rate of cytokine release syndrome. Trying to treat these has gotten better over time, as Matt has already mentioned, and then try to preventing the toxicity also. So looking at early use of steroids was shown to be able to decrease the toxicity, although a recent abstract suggested that maybe high dose steroids early on in the course has a higher rate of decreasing response to treatment. Other agents such as the IL-6 receptor antagonist tocilizumab have been used to prevent or help with higher grade cytokine release syndrome. Intrathecal chemotherapy has been used to help with neurotoxicity. There's a score developed to try to help gauge if patients are developing neurotoxicity and the grade at which that is. So I think that over time, certainly we've been able to recognize what these toxicities are and treat them earlier on to prevent them from being higher grade.
Matt, how do you look at these toxicities? And the other thing I'll ask you to comment on is, I think we focus on CRS and neurotoxicity, but there's also low immunoglobulins, infections, neutropenia, all those things that people in the community may be getting these patients back 6 months later and have to be aware of at least. So your thoughts on those?
Yeah, so I think we're still learning in the kind of what I call the day 28 and before, but we're absolutely still learning in the day 29 and beyond. And I think you're absolutely right, Dr. Leonard, with when you sending these patients back out into the community, you're having those discussions. I called it the double dip. You see the Cy/Flu cytopenias and then they recover, and then you see potentially cytopenias that occur again kind of in the mid-day 20s that can extend to where people are transfusion dependent. They do require intermittent growth factor support for neutropenia. Sometimes it's one dose, sometimes it's multiple doses, and over time what you can see is that that they can improve, and there has been data looking at that, that the cytopenias do improve. We don't really know when to often incorporate IVIG. I sort of use the CLL principles as recurrent sinopulmonary symptoms rather than an IgG level that I would start to use IVIG, given that we have a national shortage of it from that standpoint. But I, try to comfort the community physicians is that if this person is at day 100 in a CR and their hemoglobin's 8.5 and their platelets are 50 and their neutrophils are 1.1, that's good, right? Because the alternative is having those same counts in progressive large cell lymphoma. And, I think the data has shown us that it's hard to get those patients post-CAR T cell with prolonged cytopenias onto clinical trials, so they're not well represented. So I'll take a person in a CR1 after double refractory disease with persistent, not grade 4 cytopenias, but grade 3 or 2 to 3 cytopenias.
And just briefly, are you doing at Nebraska? Are you doing outpatient administration? I know that there have been some data presented at ASCO around outpatient and also kind of readmissions and other things. What's your take on that at your center?
So we do outpatient autos. We are set up to do outpatient CAR T. We were ready to do it on Transcend, but then the accrual was held. We have not done it in an axi-cell product to date. I think that it would require substantial kind of outpatient, but a floor above us in the hospital type of approaches to outpatient. I do think the data looking at the pilot, which is you're referring to, which is the pilot study with Lysocell, looking, and as well as some other experiences in Transcend, where there was outpatient administration. It looks like, if you have later onset of CRS and neurotoxicity, you may be able to get several days beyond infusion before they may need to be brought into the hospital. But I still think a fair number of people, when you start off in the outpatient, the general expectation is that you're going to spend some of your CAR T-cell in inpatient, but you may get away in a small percentage with doing it completely as an outpatient. But I think the safety profile is going to matter.
So to kind of close our discussion with on CAR Ts, I want to ask Nathan just to kind of remind the audience from your perspective of patient selection, because I think for many people in the community, they're not going to be administering, they might be, but for most people, it's going to be referring the patients. And we want to be sure that people at least know who to refer for a consultation and a discussion. But any kind of guidelines you would give people as to who to send as far as the disease, the timing, the age, CNS involvement from your perspective?
Oh, yeah. So I think that the good rule of thumb is that if you have a patient that is not eligible for a transplant, but has overall, this is a thin line, because there are patients that are not eligible for transplant, for example, because of age, but they have a good heart, and good heart meaning good ejection fraction and normal kidney function. That's a great patient to send for a CAR T cell. There's now, again, a couple retrospective looking at patients that are elderly that would not qualify for transplant and do quite well. I can tell you here, I've referred patients and have given CAR T cell to patients all the way up to age 86, and many of them have done quite well. The other large group of patients, so again, that's transplant ineligible, but otherwise have good organ function. The other group are transplant failures. Those patients should be evaluated for CAR T cell. I think it's the most appropriate and most effective option for those kind of folks. I think those are the two big buckets. Generally, chemorefractoriness, to me, I think we all know that generally means that patients don't do too well with auto transplant. So to Matt's point, in patients who have refractory disease, even before they fail their second line, I'm already thinking about CAR T cell. So those are patients that are not in the FDA label yet, but patients that are primary refractory, I think the vast majority of it going to end up with the CAR T cell. So the sooner you start thinking about them, the better.
So Cami, I think the unmet needs for around CAR T cells are very similar to where we started this discussion around R-CHOP, right? More effective therapy, less toxic therapy, easier to do. Any other kind of unmet needs that you would throw into the CAR T cell scenario? Clearly, there are a number of new drugs that are being combined, and I guess the question is, will they make it more effective or less toxic?
Yeah, I think, there's study, I think you're exactly right. There's studies looking at improving upon CAR T, so using different constructs, adding other medications, either pre or post infusion, to try to improve the efficacy, and then all the areas that you mentioned.
Great.
Yeah. And John, you mentioned, and I didn't talk about, is relapsed large cell lymphoma in the brain. So there is some data with CNS lymphomas, and now that I think about it, that is another population, relapsed large cell, that I would consider for in the brain.
Yeah, I think we've seen some small studies at ASCO and otherwise that have suggested that responses can be seen and potential value in that setting.
Absolutely.